I think we were all waiting for the LAPACT study to be presented at this meeting. And I think overall, it was a phase 2 single-arm study, and the findings that were noted, I think, was very consistent with what we were expecting. So I think in many ways it's just reassuring because many of us are already using this the gem-Abraxane regimen in clinical practice. So it's always nice to see findings that confirm what we're already doing. So I think that's my initial impression of the study. I think the design was quite interesting in the fact that patients got an induction chemotherapy for about 6 cycles or six cycles. And then afterwards, they were further randomized to either surgery or further chemotherapy or chemoradiotherapy. It was really a dealer's choice. The investigator got to choose what they want to give. So that was quite interesting. I mean, the numbers are quite small. Of the 107 individuals, only 61% of individuals actually end up in one of those arms because the numbers are quite small. It was hard to compare as well. So I think it was hard to further interpret those findings in particular. I think it's a pretty pragmatic endpoint. I mean, oftentimes when people stop their therapy, it's because of side effects or they can't tolerate the treatment. So I think for this kind of setting, it's a pretty reasonable endpoint. They also looked at secondary endpoints, which wasn't presented as fully, but I think it's reasonable to use the TTF. I think it's, again, interesting and kind of thought-provoking to have a 35% response rate. I think what's interesting is that about, I think 16 individuals actually went to surgery. And so that's about 15% of the entire cohort. And for locally advanced individuals, we always hope or desire that they can be downstage to a point where surgery can be conducted. What the presenters did not share was exactly how many R0 or R1 resections were actually done. But so it would be nice to tease that out a little further to see how many of them actually went on to an R0 resection, meaning that all the resection margins were negative and there were clear margins. I think there's no real benchmark per se. I mean, I think we always want to aim for a higher resection rate. Again, it kind of circles back to my earlier point that I do wonder what the actual surgical outcomes are among these individuals who got surgery. Did they recur? Were they cured? That kind of thing. So without that information, it's hard to know, how to interpret the number. And there really is no benchmark per se. I mean, in clinical practice, there are always the rare individual where we give some chemotherapy. They get downstage to a point where a surgeon would feel open to operating. But in my experience, many of them recur quite quickly after. So when that happens, it would suggest to me that surgery was not done. Surgery did not really provide them long-term benefit because they ultimately recurred. And when that happens, they're no longer curative or they revert back to being a palliative case. I'm always a little cautious about interpreting the median because it tells me that half of individuals did better than that and half of individuals did not do better than that. Certainly in the Canadian context, we looked at our own locally advanced individuals and many of them actually live close to a year actually. So as a discussant actually shared during the presentation, I think in many ways the 6 months or 6 cycles of induction chemotherapy really selects for us who does better and who does not do well. So for those who get beyond the median, they're probably the ones who may be good candidates or potential candidates for further treatment. And for those who don't reach that median, for example, then obviously any thoughts of a curative intent approach or surgery or further treatment is probably not worthwhile. I think there was a very nice slide comparing the MPACT study and the LAPACT study, and when they're kind of compare side by side, the toxicity profile is actually, again, very comparable to what we're used to. And in general, the gem-Abraxane regimen is pretty well tolerated. So for the occasional people who have neutropenia, we might dose delay them, skip day 15, or dose reduce the regimen. So that's the usual kind of approach to managing those side effects. Some individuals, again, will have neuropathy, and for those, again, the same approach, dose delay, dose reduce, give them a short break. So again, the numbers or the actual frequency of the side effects were not really different from what we're used to seeing. I mean, because these are locally advanced individuals, and one of the entry criteria, at least from my interpretation of the study, is that these are not upfront resectable people. So because of that, the intent of treatment is already palliative to begin with, and if they reach surgery, that's great, but that's never really the realistic expectation for the majority of patients. So because of that, I think quality of life is really important. We want to give a regimen that hopefully prolongs survival, maybe increases the chance somewhat of surgery, but at the same time, we have to temper that with ensuring that the months they have are good and not full of side effects. And again, my experience with gem-Abraxane has been pretty positive. Again, occasional neutropenia neutropenia, occasional neuropathy, but those are pretty standard that most oncologists deal with. So they're certainly not side effects that would concern me enough that I would be fearful of prescribing it. The MPACT study focused on metastatic patients, but funding for this regimen was approved for both metastatic and locally advanced, just because I think people feel that they're similar enough, yet different, to warrant funding to be applied to both groups, locally advanced and metastatic. So to see today that the findings confirm that there is likely some benefit, again, it's nice to see. But in terms of how it changes what we do, it probably would not change it. It would just basically give us further, I guess, comfort that we're doing the right thing and the right regimen is being offered. So again, I think this was an important study. It confirms to us that there's value in this regimen in the locally advanced setting. So I think that is important, finding. It doesn't really change what we do already, because in most provinces in Canada, we're already giving this regimen to both metastatic and locally advanced individuals. I'd be really keen to kind of look further or delve further, or have the presenters delve further into the second randomization or the randomization to investigators' choice of treatment after 6 cycles of induction chemotherapy. It's pretty small numbers. I think there's like 12 to 16 in each of the groups. So surgery, chemoradiotherapy, and further gemabraxane. It'd be nice to see, is there one that's better? And I know it's hard to compare, but at least to delve a little further into those numbers would be quite interesting to see, is there a clear winner? Again, the numbers are small, so I don't think we can overinterpret the findings, but at least some exploratory look at that would be neat.